The discipline of molecular oncology is one of the fastest evolving areas of modern medicine and pathology. Earlier this year, we saw new guidelines for molecular biomarker testing in lung cancer, and late last year, new guidelines for colorectal cancer. These guidelines recommend expanded gene and mutation testing to be done in shorter periods of time on smaller samples with less tumour content. Easy, right? It's a significant challenge to do all this work on these tiny little biopsies that we're receiving these days, and to do it accurately and reliably so that we can select from these targeted therapies that provide opportunities for our patients. Now, tissue testing can't achieve everything. It is challenged by heterogeneity, but also in metastatic disease, a single biopsy may not be representative of the entire disease. And this is an opportunity for liquid biopsy testing, which has also been recommended in these guidelines in parallel with tissue testing. In today's workshop, we will be hearing from two invited speakers. These speakers have applied the MassARRAY system in their clinical laboratories to overcome these challenges. So it's my pleasure to introduce our first speaker, Professor Pierre-Jean Lamy. Professor Lamy is a clinical biologist, and he is the head of the Department of Genomic and Biopathology at Laboratoire Biologie, Montpellier, France. That was the best French I can achieve, Pierre-Jean. In which he has developed a molecular biology laboratory dedicated to the detection of DNA alterations in breast, ovarian, colorectal, lung, and prostate cancer. Pierre-Jean graduated from the Rockefeller Medical and Pharmaceutical University before joining the Montpellier Cancer Institute in 1997, and he assumed his current position as the director of the clinical laboratory in 2007. Professor Lamy is a specialist in biomarkers of solid tumours and liquid biopsies. But he also, as a side activity, is the coordinator of the Montpellier Cancer Institute Biobank, and through this has led many translational research projects on prognostic and predictive biomarkers. So now it's my pleasure to hand over to Professor Lamy.
Thank you, Darryl, for this great introduction. Good afternoon, everyone. I'm going to talk on liquid biopsy and especially circulating tumor DNA and what we can expect from an ultrasensitive test in order to diagnose and to also monitor non-small cell lung cancer patients. So I will divide my talk in three parts. First of all, in ctDNA in non-small cell lung cancer. Secondly, I will talk about challenges in ctDNA analysis. And then I will show you a comparison between UltraSEEK lung panel, developed by Agena Bioscience, and the Cobas EGFR-V2 test, developed by Roche. So we are at the era of precision medicine, and we have to give the right treatment to the right person thanks to molecular tests, and especially in non-small cell lung cancer it's very important because we have to use, for example, a tyrosine kinase inhibitor in specific EGFR mutated patients. But for that we have to analyze tissue from this patient, and usually we only get lung biopsies, and as you see, lung biopsies are very teeny samples. It's very difficult to extract the DNA and to have a great molecular analysis for those patients. We have also some problem because lung biopsies carry risk, blood clots, bleeding, pneumothorax, infection, fevers, pain, pneumonia. And also it's difficult for those patients to get biopsies and to repeat biopsies for those patients because they have lung disease and it's very difficult for them to stop breathing or not coughing during this exam. And finally, for us, molecular biologists, it's always difficult to analyze those samples because it's not always informative. We get only a low number of cells, as I said before, and sometimes it's very insufficient for molecular analysis. They are very numerous now as you know. So at least, and this is in this publication made by Darryl in the GTO, at least 20% of patients had non-evaluable tissue at the time of diagnosis or during the course of the disease. So you know that non-small cell mutation are very important. It's very important for all patients to get those mutation profile and to get benefit from targeted therapy if they are mutated in these GFR genes, especially in exon 18 to 21. And we have to look at those activating mutation to give the treatment EGFR inhibitors. But unlikely, unfortunately, during the treatment, it could appear some resistance mutation, especially this T790M mutation. And it's important also to look at this mutation because it exists now, third generation of EGFR inhibitors called Tagrisso, and is active on this specific T790M mutation. So, a clinical trial compares the result obtained on tumor and on plasma to look at this resistance mutation T790M. And as you see here on the waterfall plot, the results are quite comparable, and the response rate is equivalent from the selection based on tumor or on ctDNA. And that's why this treatment is now approved by the FDA, even if you look only at the ctDNA. If this mutation is present in ctDNA, you can skip biopsy and start this third generation EGFR TKI. If not, of course, because of a lack of sensitivity of the method used in these oral trials, that was the Cobas test, it's necessary to come back to the tissue to get maybe another biopsy and to look at this mutation. But as I said before, it could be sometimes impossible. So now we have a recommendation from the CAP, from the EMP, and also SLC. Those molecular testing guidelines were updated in April this year, and those recommendations are now for clinical setting in which tissue is limited or insufficient for molecular testing. ctDNA could be used at time of diagnostic for all patients to look at this if EGFR exon 28 to 18 to 21 mutations, and in order to give EGFR inhibitors, and also at time of progression to look at resistance, especially T790M. So, but okay, we can use liquid biopsy for those patients, but it's sometimes very difficult. And we have to know the challenge that we have when we use this analyte. And I will take this image because it explains why it's very difficult. First of all, you have a high background in blood because there is also a high quantity of genomic DNA that is not interesting for us. And there is very low specific level of tumor DNA. So the picture is quite confusing. And when we want to look at that we call the guy Charlie in France, but Wally or Waldo in several countries, it's very difficult. And maybe you don't have seen him in this picture. So we have to use a very sensitive method to look at this guy. And this guy is over there in the middle of a large quantity of images that are in relation with background. And this is quite the same also in the blood, in the circulating blood. So what can we use? We will see that later. But there are also different technical pre-analytical issues based on the tube. For example, we can use blood coming from EDTA tube. It's commonly used, but there are many drawbacks, and notably also the high risk of contamination with genomic DNA due to the release of white blood cells DNA. And it's important to centrifuge this tube very rapidly after running the patient. And if you look at the quality of DNA you have a high quantity here on the right of genomic DNA. You can analyze this DNA profile with a lab chip, for example. And here you have the peak around 166 base pair, the peak of ctDNA, and this is the DNA you want to get. Maybe, of course, you can use preservative tubes, and here you have the picture with the preservative tubes. You have no release of white blood cells, and so you get only the ctDNA you want to analyze. Then there are many challenges also with the techniques, and of course we can use all the molecular techniques we have. We can use even Sanger if we have a high quantity of circulating DNA. That could be the case in advanced metastatic cancer, but it's not at time of diagnostic during follow-up if you want to look at residual disease or to have information on early recurrences. So for all those kinds of diagnostic, you have to use very sensitive methods, for example, digital PCR or MassARRAY UltraSEEK. I will present in next slides. So in order to look at these new techniques, very sensitive techniques, I've made a comparison study, and I used cell-free DNA extracted from blood plasma, and for blood plasma from Roche tubes, and I use also the Cobas sample preparation kit for extraction. And those plasma were from advanced lung carcinoma patient analyzed for somatic mutation detection. Using, first of all, the Cobas test I used before in my lab, and this is like the gold standard. It was used in several clinical trials. This is a real-time PCR, and we use 4 ml of plasma prospectively. And MassARRAY was used with MALDI-TOF detection. It's a MALDI-TOF detection. I will come back on these techniques. And we use the same samples, but retrospectively, samples frozen we had in our biobank. So if we look at those tests, the Cobas EGFR mutation test is a qPCR specific test looking at EGFR mutation only with look at 42 mutations, and the limit of detection is from 1.5 to more than 10%, independent of the mutation you look at. And the UltraSEEK lung panel, it's a test looking at 5 genes, including BRAF, EGFR, KRAS, OB2, and PI3 kinase, and looking at 67 mutations. And the limit of detection is 0.5% with the input of 20 nanograms per well. The input for Cobas is a little bit higher. The techniques of MassARRAY, generally, it's a relation with DNA to mass. And first of all, this is a PCR amplification, looking at the region you want to analyze. And then a primary extension specific to the mutation you want to look at. And then a detection with the MassARRAY, that is a MALDI-TOF system. So the UltraSEEK, it was just the classical biochemistry. To look at ctDNA, they developed UltraSEEK Biochemistry. It's the same to begin. You amplify the region of interest. And then this is a specific multi-single base extension using butynylated terminating nucleotide specific of the mutation you want to look at, okay? And then there is a phase of capture of this specific primer extended, but the capture is specific for the mutant allele only. The capture is made with magnetic bead activated with streptavidin, and then you have the MassARRAY analysis. And as you see in this picture, you don't have the signal of the background. You have also only the mutated signal. That is so very specific because you have no background in the picture. So you increase the signal. So the phase is always the same. You use 10 to 20 nanograms of cell-free DNA, then multiplex PCR, an extension, and this is for non-small cell lung cancer, 12 tubes, for base extension multiplexes, and then a MassARRAY analysis. It takes 1 day to do that. And this picture just to remind you that if you want to look at very specific, very sensitive methods, you have to remind that when the input is very important. If you input, for example, 20 nanograms, you have to look at 6 molecules if you want to have a sensitivity of 0.5%. So it's very important to remind that, because you have to keep in mind that it's the analytes are at very, very low level. So let's have a look at the results. The study including 31 patients with advanced lung cancer, and we had 12 patients mutated that are currently treated under TKI, but they were at time of progression. So for those patients, we look at resistance mutation. 17 were at time of diagnostic, but with no tissue available, and we have the 2 patients with no clinical information. First of all, we get no invalid result, even with the Cobas test. 100% of the USK wild type were also Cobas wild type, okay? And 100% of the EGFR mutated Cobas were also mutated with the EGFR UltraSEEK lung panel. That means we didn't miss any mutated patient with this new test. And we had also 100% concordance if we look at the T790M mutation specifically. But we had some discordance. And if we look at the different kind of patients, and first of all, if we look at the patients that are mutated under TKI, we get 3 more patients EGFR mutated with the USK panel. If we look at the patient at time of diagnostic, we get 5 more patients. And if we look at those patients with no clinical information, we had 1 more patient with an EGFR mutation. You can see here the 10 discordances we get finally. So as I said before, 9 patients mutated on EGFR with the USK panel. This is 1, 2, 4, 5, 10, 11, 20, 28, and 31. And for all those patients, if you see the allele frequency here, yes, you have here the allele frequency we get with the USK panel. All those patients presented a mutation lower than the limit of detection we can expect with the Cobas test. Okay, and for example, patient 2, we get here this mutation 0.131. It's wild type with the Cobas. Of course, here the limit of detection is 1.40%. Okay, we get also 2 pyruvate kinase mutation with the UltraSEEK test. Of course, those mutations are not searched with the Cobas test. And also we get 2 EGFR mutations that are not searched because the panel is not comprehensive. The Cobas panel is not comprehensive, so we get those two more EGFR mutations. And as I said, all mutations detected with the USK panel only at an allele frequency below the limit of detection of the Cobas test, except for the patient 20, because the patient 20 had a mutation that is not detected by the Cobas test, and you can see here, this allele frequency that is over the mutation limit of detection. So, of course, we can ask about the specificity, and I don't have to compare for all those patients the tissue, but I will present you the result obtained by Klaus Pantel, and these results were presented at the AACR this year. And as you see, concordance between tissue and liquid biopsy is quite high with the USK panel because it's like 90%. So we are quite confident about the specificity, and I had now a new result I cannot show now, but with a different kind of cancer, and we didn't find any non-specific mutation for EGFR genes. So, to conclude, I would say that UltraSEEK lung panel presented a higher sensitivity in a larger panel, and that has some consequences I will develop there. We can have a better concordance with the clinical evolution. I mean, it's possible to monitor more patients that have those kind of mutation. We have a higher level of mutation at time of diagnostic, and that allows for those patients to be treated with a TKI, and that's, of course, very important. It's also possible to evaluate new mechanisms of resistance because we look at several genes like pyruvate kinase and KRAS, that those genes are very important, for example, for TKI resistance also, and they have been presented also to be important, for example, for immunotherapy response prediction. And you can also use the variant allele frequencies, that is very reliable in this test, to monitor those patients, and it could be very important also for immunotherapy. So thank you for your attention. I would like to thank also all the patients that have been included in this study. They are coming from the Institut Occitan du Cancer, Institut Sainte-Catherine in south of France, all the clinicians implicated in this study, and also Dr. Sartori from Agena Bioscience for his help. Thank you so much for your attention.
We might hold questions until the end, until after our second speaker has talked to us. So it is now my pleasure to introduce our second speaker, Professor Doug Demetrick. Doug is the Laboratory Director of the Molecular Pathology Laboratory at Calgary Laboratory Services. CLS MPL, established in 1985, performs molecular testing of DNA and RNA specimens to provide diagnostic, prognostic and predictive information to laboratory physicians and clinicians in order to guide optimal care for patients with cancer and other diseases. The laboratory utilises a variety of technologies, primarily the MassARRAY platform, to perform complex testing of cancer genes, genomic alterations and pathogens from tissue, blood or fluid specimens. Dr. Demetrick is a Canadian and US certified anatomical pathologist. He obtained his doctorate in immunohistochemistry from the University of British Columbia, completed his medical training, internship and anatomical pathology fellowship at the anatomical pathology residency at the University of Calgary, and he was also the CIHR clinician scientist in molecular biology at Cold Spring Harbor in New York. He is also, in addition to all of that, do you have any time left? He is also a faculty member of 4 different university departments, including pathology and laboratory medicine, oncology, biochemistry and molecular biology, and molecular genetics at the University of Calgary, running research laboratories in those different departments. So, over to you, Doug.
Thank you very much for the generous introduction. As has been alluded to, I'm more used to giving presentations on esoteric molecular biology topics like cell cycle regulation and upregulated targets of hypoxia. But I'm going to put my clinical laboratory hat on today, and hopefully this talk will be more intelligible than usual. I'm talking about practical applications of the MassARRAY platform in a diagnostic laboratory context. And we'll go through our testing and how our lab has benefited from the introduction of Agena MassARRAY platform. But first of all, I need to disclose that I've been a consultant to AstraZeneca and Bayer Canada. I receive or hold intellectual property related to the use of molecular and protein-based testing for P16. And I've been paid honoraria by Agena for presentations. Before I go into the actual application of the technology, which has been very nicely explained in several different contexts by Dr. Lamy, I'm going to tell you a little bit about the Canadian laboratory medical system. It's a little bit different from the US, and you can see that we have different pressures that we need or are forced upon us to make decisions. In Canada, all essential healthcare services, including laboratory testing, are provided through government funding. In our case, the government of the province of Alberta, which is a province that sits directly above Montana. Only non-essential healthcare services can be billed through either a third party or through patient pay, and cancer-based testing is an essential healthcare service. So we are funded entirely by the province of Alberta for diagnostic applications. Calgary, the city that Calgary Lab Services is the exclusive laboratory services provider, is a city of about 2 million people. And CLS provides about 35 million lab tests a year, of which 400,000 are surgical pathology evaluations. Our budget is about $300 million, so that I think puts the global laboratory into context. The molecular testing, which includes provision of testing to support quaternary care hospital, that's the academic hospital for the University of Calgary, consists of 5 different specialty laboratories, of which molecular pathology is one, and I'm specifically talking about molecular pathology today. So molecular pathology, prior to the introduction of Agena technology, evaluated lymphomas, solid tumors, primarily gateway testing for designer drug therapy, pathogens, and some esoteric tests that you would expect in an academic center, including microsatellite instability, MGMT, methylation, and specimen identification, mismatch, chimerism applications. The testing, particularly for sequence variants, is provided by a mixture of commercial single test assays and our own in-house developed laboratory tests, primarily using either TACMAN or snapshot methodology. And our utilization, I'm sure, like everyone else's, is increasing at least 20% a year, which is driving our finance department crazy. And they were very relieved when I put forth a business case to upgrade our laboratory infrastructure to have a platform to consolidate as much of our testing to a particular platform as possible. How I sold it to them was that we would decrease the cost of testing. And they certainly are holding me to that. But what I really wanted was an increase in our capacity, not only for diagnostic use, but also for our capacity to provide contract testing services to support clinical trials in our academic environment. Now, we had certain criteria that we wanted to ensure were satisfied with the new platform. And that included the ability to standardize our methodology and analysis as much as possible. We had SOPs for each of the different tests, and the potential for laboratory error in that complex methodology environment is significant. We wanted to ensure that we conserved our analytical sensitivity, at least not to go backwards in terms of analytical sensitivity, and same with our turnaround time. We wanted now to gain abilities to do multiple testing of our specimens. Rather than using an aliquot of specimen for each particular test, we wanted to conserve our specimens and do a panel of tests from one small fine needle aspirate, for example. We wanted to ensure that we had flexibility to add new tests and to add them in a simple manner. We support academic researchers, and I'm an academic, and I wanted the ability to add my own tests to the platform. We wanted also the ability to potentially provide genotyping services in a pharmacogenomics context, which we have still not yet initiated, really because there's no capacity to fund this at the moment. And we also wanted, as much as possible, to avoid the responsibility for tracking variants of unknown significance. So we looked at some potential technology in addition to Agena. The technology primarily evaluated consisted of 3 different next-generation sequencing platforms to properly prepare our due diligence in our business case, and everything in CLS is expected to be business cased. We ensured that we could calculate the cost of our current testing on a per test basis, and anticipated cost of testing on each of the platforms, including the Agena platform. I show a spreadsheet that's very conveniently provided by Agena, but we actually did this on a per test basis. And then we also looked at the costs over 5 years, where we expected to amortize the cost of the instrumentation to ensure that over that 5-year period, we knew what our true costs would be, at least as close as possible. So how did we do? With the Agena, we found that we expected a cost in the $100 range per assay versus anticipated costs with the most cost-effective NGS platform at the time. This is about 18 months to 2 years ago, of about $400. We certainly had an increase in our test capacity. We chose to use a 2-instrument 96-well configuration, and that would provide at least 40 specimen tests a day and likely more. We wanted to ensure that not only was the methodology standardized, which of course it is with a single platform, but that we also were able to improve our automation and get away from our dependence on primarily manual methodology, which made our finance department quite a lot happier. We ensured that by selecting the Agena platform, we could theoretically retain our analytical sensitivity, and in many cases, especially with like snapshot-based assays, we'd improve it. Our turnaround time was conserved, and we had the flexibility to add not only new targets, but also entire new panels, which we very happily seized upon. So before we implemented the testing, we had to validate this platform. All of these tests are LDTs. There are relatively few Health Canada approved tests. FDA doesn't work in Canada. They insist on Health Canada evaluating, and they're not always granted approval. And it's an expensive proposition for most test vendors to go through the bureaucratic challenges in Canada, and they choose not to. So we have to validate these as LDTs. So we chose a minimum of 30 specimens to evaluate, but in all cases we actually used more. It's very convenient for us to keep useful specimens around after we've used them diagnostically, and especially those great contrived cap specimens, because there are often multiple sequence variant targets in those guys, so we like to keep those around. So if you're contemplating a change in technology, and rather than have to go and prospectively identify your specimens that you're going to use for validation, keep those useful samples around in their DNA form. We know our assays are working on a per analyte basis by being able to see the wild type primer extension signal from Agena technology. And so we evaluated the most common potential targets, because that's what we had. And there are targets that we still, in my practice life, have not seen yet. When we do run into those, we will sequence those or use an alternate diagnostic test to confirm that target. But most of the validation was done with specimens that we'd previously used on our other validated LDT platforms. And as I said, prospectively, if we identify new targets, we confirm them before they're reported. Okay, so for our in-house validation of our colon HS panel, we obviously obtain very high sensitivity and specificity, and this is an example of the spreadsheet that we used. And you can see that there's some colored cells that represent discordance between Agena and our other tests. Some of them, in fact, most of them were new pickups from Agena that repeated. So we're happy that they were most likely true positives based on a higher analytical sensitivity. But nonetheless, we use them in the calculations as discordance, and in spite of that, we still have sensitivity over 95%. Likewise, we evaluated our custom Neuro cancer panel, and we had no discordances with the positives from the previous assays, and we had I think one well where we got a very faint potential positive that was likely a false positive, and we included that in our calculations, but still the sensitivity specificity is fantastic. Now, we also wanted to introduce liquid biopsy testing into our laboratory in a clinical context, and that technology and evidence supporting the use of this platform has been very nicely presented already by Dr. Lamy. So I'm going to tell you our practical approach to it, and that was to evaluate the specimen preparation and I guess incubation, or the delay between specimen collection and analysis, by evaluating two different methods of fixation. We looked at the analytical sensitivity of the platform using titrated and commercially available controls. We looked at being able to purify doped control out of plasma, patient specimen plasma, to ensure that our purification methodology was appropriate. We ensured that our false positive rate was low, and in fact, we identified no false positives from a series of 40 anonymous plasma specimens. We identified one that reproducibly had a KRAS mutant in it, and so we think that was probably a true positive. It reproduced, and the patient, because they're anonymous, we had no clinical history, could easily have had a malignancy on board, or it could be a result of clonal hematopoiesis. And because it repeated, I think, 6 times in that particular specimen, we chose to call that a likely positive, and that didn't influence our false positive rate. We also participated in an external quality assurance program, and also with the clinical specimens that we started to test, we ensured there's concordance between the driving mutation that was identified on the original tissue evaluation with the EGFR non-T790M mutant that we could identify from the liquid biopsy. So we had, I think, a relatively rigorous approach to evaluating our liquid biopsy testing protocol. Of course, we were assisted in not having to reinvent the wheel by standing on the shoulders of others. For example, Marotra's work and also Sherwood's work were very helpful to us. And I recommend that people thinking of initiating this testing use those and other papers that talk about pre-analytic variables and methodology. Just an example of what we obtained when we evaluated the analytical sensitivity of the platform. A very low background in the absence of a T790M, a very nice mass signal from 5% allelic prevalence, again clearly observed at 1% and even observed at 0.1%, and this varies. Usually this shows up a little bit better, and so this was about the worst we could observe. We chose to establish our analytical cutoff at 0.2%, and that is quite reliably observed by eye and is called by the instrument. The instrument actually called this peak. Of course, we have much more confidence in our T790M negatives if we can identify the original driving mutation, and so the UltraSEEK lung panel that we use ensures that we can capture most of the relevant EGFR mutations. 1% of the L858R and 0.1% is clearly identified here, and obviously called by the instrument. We participated in a pharma-sponsored external quality assurance program that was nationwide across laboratories thinking of introducing liquid biopsy technology, and we had 100% concordance with the specimens that had greater than 0.05% allelic prevalence. So again, we had quite a bit of confidence in the accuracy of our testing methodology for liquid biopsy using the Agena platform. Yeah, we did find some things that we didn't like about the platform. Primarily, they concerned analysis and the time spent having to analyze some of the complex data. We also found that the instrument needed to be tuned a little bit more frequently than we'd anticipated, which my lab tells me is actually not a big deal. With regard to the reporting and the templates that are provided with the Agena derived panels, for example, this would be the lung HS panel. If we use a peak intensity of 8 as a gate, we get a very nice clean panel with a variety of sequence variants clearly laid out. If we use a peak intensity of 4, we find a lot more potential false positives. We need to evaluate all of these by eye. They're very quick. It's very quick to do because they're quite obvious. The machine is very sensitive at calling at this particular peak intensity. However, if we use a higher peak intensity, we lose some of the positives. They're gated out in our 2% control. And our 2% allelic prevalence control is where we like to establish our threshold. So we would rather eliminate these potential false positive calls by eye, which adds a little bit of analysis time in order to preserve our ability to identify true positives in the 2% analytical prevalence control. The custom panel is a little bit more difficult to analyze because we don't get that beautiful template, but the approach is the same. Basically, we analyze, evaluate by eye anything that's called by the instrument medium or high. I'm not sure if we've ever eliminated a high, but we've occasionally found some positive mediums that we were quite happy to change to green. This actually represents what I look at when I sign out. The spectra for each of these greens is available in the spreadsheet, and I confirm those before I sign out the report in our LIS. So our outcomes from our MassARRAY were quite positive. Our major driving force was cost effectiveness. Did we achieve this? Well, we were thinking in the 100 range. Our lung HS test after a year of use comes in at $145 Canadian. Our colon HS around 142, and this is an all-in cost, including DNA extraction, analysis time, and my sign-out time. Our custom Neuro is at $95. We anticipated a cost using NGS of the 400 to 500 range, depending on the platform. And our real costs for Agena are about 50% the real costs of our testing on a per test basis prior to introduction of the platform. So I think our lab has achieved around $200,000 in cost savings the first year of use. Validation went very smoothly and quickly. We were up and running with the tests already validated for 3 different panels, including our custom neurocancer panel, within 4 weeks of unpacking the crates. And our analytical sensitivity was at least conserved and most often improved over our previous methodology. So over the past year, since the introduction, we've looked at approximately 600 lung panel specimens, 350 colon, 273 neuro, and then we've introduced some of these other tests since a year, and so they're extrapolated to an approximate year use. HPV testing is likely to be an understatement. I suspect that it's going to increase significantly, but we've only, I think, introduced the test about 3 months ago. Our current menu then has about 70% of our testing consolidated to the Agena platform, which again made our risk management and finance folks very happy, and our technologists very happy because the SOPs were greatly simplified. I'm going to present a little bit more granular approach to our practical application of this technology in December as a webinar, and I'll have obviously discussion of some of the other tests like the lung fusion and the HPV testing, and some more on I think the UltraSEEK testing as well then. So I'd finally like to thank Bob Winkfine as our lab scientist, and Marco Parasolo as our lab specialist, who really led the implementation and validation of the Agena platform in our lab, and Dr. Priscilla Hunt of Agena, who, like all of Agena's technical support staff, has been an excellent resource in designing and in debugging issues with the platform that we experienced when we first set it up, as we had no real experience with the analysis. Thanks very much.
Thank you, Doug. We have some time for some questions. There's a microphone at the center of the room, or you can just yell it out. Yes?
How complex are you
The Neuro panels were put together at the request of, I think we have 6 neuropathologists, and they represent a standard ID, for example, IDH 1 and 2, but also P53, P10, and a variety of other targets in that panel that our neuropathologists like. So offhand, I can't remember. I think there's like 60 or so, there's I think 70 targets with our custom neuro panel spread out amongst 5 to 7 genes. Not all have been validated. I think there's 2 that there really hasn't been clinical demand for. So we've accumulated mutations, but I don't sign those out. P10, I think, for one, is we're not signing out. We could, but they've indicated that they don't have a demand for it at the moment, so I don't sign it out officially.
So these are amplified in multiple?
Nope, these are all sequence variants. So all of our panels are sequence variant panels, except for we use the lung fusion panel. We don't have copy number panels yet. We're thinking of implementing a gene amplification panel that would contain EGFR, for example, HER2, and GLI and MDM and CDK4 targets, for example, but we have not implemented, validated that target, that panel yet.
These targets are amplified in a multiplex PCR and then?
I'm sorry, yes, in terms of the amplification, yes, they're amplified. I think that panel is spread over 4 or 5 separate PCRs to get the 70 targets. It varies on the efficiency of the multiplexing, but yeah, it's like that. The HPV panel, I think that has 19 and two targets, DNA quality targets, is in one single multiplex. Now we're extending a wild type sequence, so those aren't sequence variants per se, but that's quite a complex mixture that's in a single PCR reaction.
And does it include also indels or only SNPs?
Nope, it includes indels in the context of EGFR, for example, yeah. I think BRAF, I think there's a couple of indels in the BRAF panel that we use for the colon, primarily colon, but can't remember. Certainly our new melanoma panel does, yeah.
V60 and
Yeah.
Yes, up the back. The question is, are we considering going to the FDA with the system? We actually had our system registered with the CFDA last week, and we do have plans with the FDA as well. CFDA is the China FDA.
So I got a quick question for Dr. Lamy. So Dr. Lamy, you mentioned about the 2 platforms, some of the limits of detection. And I know this question comes up quite a bit for liquid biopsy applications. Can you give us a sense of what the ideal limit of detection really needs to be? Is there any need to be even more sensitive than I think you mentioned 0.5%?
The question? I'm not sure about the question.
Oh, sorry. You were talking about the limits of detection of the 2 platforms you presented on, and you mentioned UltraSEEK can go at least to 0.5%. Is that the ideal limit of detection for liquid biopsy applications? Is there any need for any higher sensitivity platforms?
I don't know if there is an ideal minimum of detection. Of course, there are not a lot of data about the variant allele frequency and the response to treatment. But we have seen for the detection of T790M, for example, that the presence of T790M is completely related with the response to Tagrisso. So, of course, maybe we need some data to look at the real impact of allele frequency and very low allele frequency, but I think it's always important to get a very sensitive method, because the variant allele frequency for circulating tumor DNA is not always related with the frequency, the same frequency in the tumor content. So sometimes a very low quantity of circulating DNA is related with the presence of high amount of mutated or high amount of tumor burden. So,
Thank you.
If there's no more questions, I'd like to thank you for attending our symposium today. There are sheets in front of you if you'd like more information. We can send you via email if you'd like to fill that out. And of course, we do have a reception desk out the front and a booth in the exhibit hall if you'd like to come and speak to any of our staff and specialists. I'd also like to remind you we have another workshop in an hour's time that is on chimerism testing in bone marrow engraftment monitoring. If you're interested in that area, please do come along. Thank you.